Welcome to the EKG guy. If this is your first time, I'm glad you could join us. So here we're going to talk about pericarditis, but I want to shift the focus from not only pericarditis, but how do we differentiate it from benign early repolarization, or that early repolarization pattern that may not be so benign after all. So what we want to look at, and we've touched on pericarditis before, and just to go an overview, just so those that you have that missed last one, is this is on our site. So if you go to www.ekg.md and put in pericarditis, you'll get this, okay? And there's a lot more, but let's just go over what we've discussed, okay? So pericarditis represents both an acute or chronic inflammation of the pericardium. Remember that there's characteristic exam findings that retrosternal pleuritic chest pain that radiates to the trapezius, okay? That's worse when you lie flat, so it's positional, and then those that stand up or sit forward, leaning forward, will have some relief of that pain. They'll feel short of breath or dyspneic, and they'll often be tachycardic, okay? Their rate will be fast because of either pain or fever that may also be associated with it. Now, you may have a pericardial friction rub, okay, or effusion. Now, if you remember, there are 2 out of the 4 that you need to make the diagnosis of pericarditis, okay? One would be the characteristic chest pain syndrome, okay? 2 would be the EKG changes that we've discussed, so the diffuse ST segment changes, okay, often because of epicardial involvement. You may have myocarditis, and if you do, you want to make sure you get a troponin and make sure you're not getting any myocardial involvement as well. But the EKG changes are the ones that we've discussed before, the diffuse concave ST segment elevation and PR depression throughout most of the limb leads, okay? And then also the precordial leads. You'll also see the reciprocal, or pretty much the mirror image of those changes, ST depression and PR elevation in AVR and sometimes lead V1. Sinus tachycardia, as we mentioned below, can sometimes is common in acute pericarditis because of the pain or effusion or the fever that may be associated. Okay, so one thing you want to do besides these EKG changes is look for a rub, okay, the pericardial friction rub on exam, and the fourth one is an effusion, a pericardial effusion. If you have 2 of the 4, you've made the diagnosis for acute pericarditis. There's a number of EKG stages that are present, okay? In stage 1, the first 2 weeks, you'll see the widespread ST segment elevation, okay, and PR depression with those reciprocal changes in AVR, plus or minus V1. Stage 2, the first 3 weeks sometime, okay, you'll have normalization of those ST segment changes and generalized T-wave flattening, all right, and then after the T waves will become inverted, so you have T-wave inversion after flattening. In stage 3 and stage 4, you get normalization of the EKG, okay, so those are the findings. And again, if you want to look for more, and we'll go over some of that, go to the site and put in pericarditis here in the search bar, and you'll get this page with a lot more information. Some of you have asked about the lectures, where you can find them. Again, go to the website and then look at lectures there, and you'll find them. If you want our course or books, you can obviously go here and get them. Okay, so that's just a few resources you have available. All right, let's move on. So again, our focus here is going to be pericarditis versus this early repolarization pattern, okay? Still benign early repolarization, but let's call it an early repolarization pattern versus pericarditis, okay? So both of these conditions are associated with concave ST elevation, which makes it difficult to distinguish these two. There's a few ways that we can distinguish them, and I want you to kind of remember them because they're quite useful, and some may be new to you. So the 2 ways that help differentiate are the ST segment, the T-wave ratio, and a fishhook pattern. So these are 2 key things that we'll look at moving forward, okay? The first one that I want to look at is this ST segment T-wave ratio, this first one here. And you'll find that here, okay? And what you want to do is, if you have an ST segment, the T-wave ratio, that is greater than or equal to 0.25, okay, or 25% of that, you'll see that suggests pericarditis. So what do we mean by this? Okay, so what you want to do is measure the vertical height of the ST segment elevation. You want to do that from the PR segment to the J point. Okay, so if you just recall, if we draw our complexes here, remember that our PR segment is this portion here from beginning to end. Okay, this is our P wave. This is the PR interval. So we're using this PR segment here, okay? And you want to go over, across, and find the J point, which is this point here. This is the J point, which is the start of the ST segment or end of our QRS complex. Remember, this is our QRS complex, this is our T wave, and this is our ST segment. The J point is that initiation of the ST segment. So you want to pretty much, if we draw it out again, okay, draw across the PR segment, okay, then you find the J point, draw a line there, and you want to take this in here, this ratio there, so that's going to be one of your numbers, okay, on the top. Let's say that is about 2, so imagine that's 2 small boxes, so we'll put it on the top, and then you want to measure the height of the baseline, which we've considered this, okay, to the top of our T wave amplitude, all right, up here, all right, and imagine that's another 2, so let's call the bottom number 4, all right, and as you can imagine, 2 over 4 is 0.5 or 1/2, and that is clearly greater than 0.25, and these findings suggest pericarditis. Now, there's a specific lead you want to look at, and that is V6, okay. So V6, not just any old lead, you want to look at V6, okay? So hopefully that makes sense. This is the ST segment to T wave ratio, and if you have this that is at least a quarter, 0.25 or more, that suggests pericarditis. That's a very helpful way to use, okay? So hopefully that makes sense, okay? You're using the ST segment, which is this portion here in green, and then we're using here the T wave segment, okay? And that's why it's called the ST segment to T wave ratio. Hopefully that makes sense, okay? So that's one way, and that suggests pericarditis. Now there's another way that suggests benign early repolarization, and that's called the fishhook pattern, okay? That's this number 2. So now we have the fishhook pattern, and that's this one down here. And this one, if you see a notched or irregular J point, or what we call a fishhook, this suggests that early repolarization. And this is best seen in lead V4, okay? So V6 we were talking about for this one specifically, but this one here is best seen in V4, okay, this fishhook pattern. Okay, now even though this is best seen, you want to make sure that you're measuring number 1, this first one, in V6, okay? You can't switch that. So this is best seen in V4, and this fishhook pattern suggests benign early repolarization, or that early repolarization pattern. So notice here, it's this here that I've circled in green, okay? You can see it looks like a fishhook there, okay? So that's the fishhook pattern suggesting early repolarization. So let's go over a few others that suggest early repolarization. So a few things. ST elevation that's limited only to the precordial lead. So limited to the precordial lead suggests early repolarization. So all these that we're going to discuss are those that favor early repolarization. So something that's limited to the precordial leads, ST elevation, that suggests early repolarization. Remember, with pericarditis, we had it diffuse. Okay, we saw it in other limb leads as well. Whether it's the inferior or lateral limb leads, we're also seeing that. Now, it could be localized, but just know that with early repolarization, this tends to be limited to the precordial leads. So if you see elevation as well in the lateral or inferior limb leads, it's likely not early repolarization pattern. You won't see PR depression, okay? So PR depression will be absent. Remember that we said that with pericarditis, we saw PR depression associated with the ST elevation in those many of the leads. The T wave amplitude will be increased, okay? Notice here that this is an early repolarization pattern, and these T waves here are much more increased compared to these ones here. Okay, so this is the benign early repolarization pattern, and this is pericarditis. Okay, so notice that the difference in those T waves. The T wave amplitude is increased here and more prominent in benign early repolarization. The ST segment, the T wave ratio is less than 0.25. Okay, so that's a key one. That's the one we discussed up here for differentiating the two with pericarditis. So if it's less than 0.25, all right, say it was 2/10, so you had 2/10 small boxes, which may make sense. Look, if you look at this one here, imagine this is lead V6, you can see that it's clearly less than 0.25, that ratio, the ST segment to T wave ratio. The fishhook pattern, if it's present, often we see it in V4, okay, that's the best lead to look for it. That would suggest early repolarization. And then EKG changes that remain stable over time. Remember, we talked just previously that in pericarditis there were different stages over weeks. Okay, so these here in early repolarization are stable. That's a few things to note. Now let's look at an example. Okay, this is an example we've looked at before in which we saw pericarditis. Okay, and let's see why that's the case. Remember, we saw diffuse ST elevation in the inferior leads. We see some elevation AVL in 1. We see some elevation in V3, V2, V4, V5, V6. Okay, so quite a few leads. And then we see depression in V1 and AVR. Okay, we see a little bit of PR elevation here in AVR, and we also see some PR depression in some of the other leads. Lead 2, we see PR depression, okay, there, maybe a little bit in AVF, and so forth. So this was a pattern that we saw with acute pericarditis. Now let's see why this is not early repolarization. Well, let's see. These are the ones that we just discussed favoring early repolarization. Is the ST segment elevation limited to the precordial leads? No, we just said that it's pretty diffuse. Okay, so this is not there. Is there PR depression? Yes, we saw it. Well, in early repolarization, we said it's absent. So this is not correct either. Okay. Do those T waves look increased and prominent in amplitude? Well, maybe somewhat here in the lateral precordial leads, but overall not so much. They're not as prominent as the ones we saw before. Is the ST segment to T wave ratio less than 0.25? Well, if you look here, remember we said that if we take V6 and measure that out, okay, so that would be the ST segment. And then you'd also want to measure the one for the T wave, okay? And it looks like it's clearly more than 0.25. So that's also not there. Is there a fishhook pattern present in V4? Okay, so V4, we don't see that fishhook pattern. Okay, look here. You don't see that. Remember, the fishhook pattern had something where it went like this. Okay, looked like that fishhook, and you don't see that there. So look back at the other slide and you'll see that more clearly. So we don't see that. So in early repolarization you'd see it present, but we don't here. And these EKG changes, are they stable over time? Well, we know that patients had this for about 12 hours. We don't know if they're stable, so this one we don't know. But the majority of them, there's 5 there that we've already said, do not favor early repolarization. So when you distinguish between pericarditis versus benign early repolarization, this EKG is most likely pericarditis. Okay, the patient, 63-year-old male, actually presenting with symptoms, 12 hours of pleuritic positional chest pain. Remember, when they lie flat, it tends to be worse, okay, compared to when sitting upright and leaning forward. That helps, that's that position. When they breathe, it tends to be worse, the pleuritic chest pain. They may be short of breath. The EKG changes we see here, so it already meets 2 of the 4. Remember the 4 criteria? Okay, you need 2 out of the 4. 1 was the characteristic chest pain syndrome. We've met that. 2, EKG changes. We've met that. So you've already diagnosed pericarditis. Now what are the other? It's 3 and 4. Okay, 3 and 4. 3, you need an exam, so pericardial friction rub on exam. And the fourth one is a pericardial effusion. So either get an ultrasound at bedside or an echo to help show that, or even any sort of chest imaging that can show any fluid around the heart. Okay, but clearly we've met it with those first two criteria. All right, so this is clearly pericarditis and less likely benign early repolarization. So hopefully you remember those. Hopefully you found those helpful to just keep in mind. Okay, so just to review them again, things that favor early repolarization is ST elevation that's limited to the precordial leads. Often it's V2 to V4. You tend to see this. PR depression is absent in these. Remember, we see it in pericarditis. T-wave amplitude is increased and more prominent compared to pericarditis. The ST segment to T-wave ratio, okay, is less than 0.25, and there's often that fishhook pattern. So these two things here are the two key things, and I think they're quite interesting, okay, to keep in mind, and things that you can share with your colleagues. So hopefully that's something helpful for you. And then the EKG changes over time. They tend to be stable with this. Remember, we saw the different patterns over weeks with pericarditis. Okay. All right, so and just before we end here, I want to make this aware of our EKG coding reference that you see here on your right. Okay, this is our on-the-go, readily available access EKG reference. You can see you have different atrial abnormalities, left-right atrial enlargement, rhythms, both sinus, the atrial, AV junctional, ventricular, ST segment changes, clinical disorders. There's a number of other things that you can't put here. But as you can see, here's even acute pericarditis. And then we have examples, as you can see, of each, and it's quite helpful. I'll start to add the videos, okay, so you can have that, whether you're in a car on a trip or just trying to study for an exam. This will be a helpful, useful reference for you, okay? Or if you're in the hospital or clinic and just want to make sure, review things, or you're not missing anything. So a few things before you go, how you get access to this. Here's the link, okay, so go to that link. I want you to enter your email, so you would put your email here, okay, and then you're going to use my password here to get the free access. So enter my password, you'll get free access to this, and you'll have it. I think you'll find it useful. It's continuously updated. We use it a lot here with Clinic, and a lot of our teaching is used from this, so hopefully you'll enjoy it. Okay, so again, your email, put that in, click submit, you'll get an email, confirm your email, and then you'll have free access to it. Okay, so make sure to get it while it lasts, and I think you'll find it helpful. A few things. If you really like these videos and you find them helpful, I'd really appreciate if you'd like or leave a comment below. Both would be amazing. Really appreciate your time and willingness to listen and put up with me and just hear what I have to say. Hopefully it's useful to you. So if it's helpful, please leave something below. It would be greatly appreciated. Do you have a topic in mind or something you want me to discuss? Now leave that below as well. I'm always looking for good topics, something that I can learn from, and then hopefully learn with you together. So if you have a topic, we have a number of them and requests that have come in. We'll use those. But if you have anything, please let us know. Okay? And then if you want more practice, make sure that you go to the website. Remember, the website is www.ekg.md. Okay, so go there. We have a number of practice things. We have lectures if you want to contribute, and then our EKG course. Okay, I probably don't say enough about the EKG course because I don't want you to feel like I'm advertising to you, but the EKG course is something we use for all our students. It's now used here by our electrophysiology lab in training our new techs and those coming in here at Mayo Clinic. Okay, so we're putting together a new course. I think you'll find that the most useful. I know there's the free lectures that you're getting online, but the most high quality content, and hopefully the best content, is here in the EKG course. It comes with a book, over a few hundred videos, and practice as well. Okay, and that takes anyone from a beginner to advanced level. Okay, not any of those Dubin's or Thaler's book that you get read and are very introductory, and They have their role, but I know from myself when first learning EKGs, that was a very inefficient process and left me with very little clinical applicability. So, would I recommend those books? Yes, if you had nothing else, but uh, honestly, I would like you to not go through the inefficient process I went through. So check that out if you're interested. Otherwise, there are a number of 100 videos here on YouTube as well. All right. Well, thanks for listening. I hope you have a wonderful day. Thank you for making us the largest, fastest growing EKG community in the world.